questions than answer. But certainly being the last panel of the last day, it's difficult to come up with a lot of things that haven't already been said. But I think what we're all going to try to do here is just add some color and propose some other frameworks for enhancing this conversation. So when thinking about the costs and the costs associated with treatment as prevention, there's multiple different layers that we need to consider. The first is what within CHAI, and I think others have often termed these above facility costs. So these are costs that are more about the health system, the costs of the ministries of health, the costs of the supply chains, the costs of national coordination amongst facilities, the costs for the central medical stores, integration of services, etc. There are also, when you look at actual spending, for example, on HIV and AIDS, we also obviously have a number of expenditures that are going towards donor coordination, donor support to these countries, technical assistance, etc. So these are all cost buckets that definitely need to also be taken into account when thinking about what the cost of treatment as prevention is, and then as a result, its cost effectiveness. The second category that I propose discussing, and this is where I'll double-click a little in the context of my presentation, are the facility costs. So these are the very direct costs tied to the provision of services within any individual facility. And then thirdly, as the last panel discussed, and as we've been hearing throughout the rest of the week, has been the costs associated with the community, with community mobilization, testing, linking patients to care, the use of community health care workers, adherence support, etc. So as I mentioned, given the limited amount of time we have here, I just wanted to focus a little bit on some facility level costs and some data that has come out of some recent research CHAI did in 5 different countries in sub-Saharan Africa, where the focus was to really understand what are the main drivers of cost at the facility level specifically. The categories included here were ARVs, labs and diagnostics, personnel, the other category here, which includes OI drugs, nutrition programs, staff trainings, and the fixed costs tied to the buildings and equipment. And as you can see by the pie chart on the right, the vast majority of the costs of providing care at the facility level can actually be attributed to the price of ARVs themselves. So I thought I'd share a little bit about what we're seeing in terms of drug pricing trends, as these will clearly inform the decisions around what countries can afford, and in the conversation afterwards answer any questions that you may have. So first and foremost, if we look at some of the most commonly used regimens and increasingly used regimens for first-line treatment, we can see that the costs have decreased dramatically even over just the last 5 to 6 years. And for many of these regimens, specifically the tenofovir-based regimens, we would expect this to continue. CHAI right now is in the process of finalizing our negotiations for the 2013 ceiling prices. These are the, as we use the term, ceiling, the highest level prices that we expect countries within the CHAI procurement consortium to have to pay for these molecules. For the tenofovir 3TC and efavirenz fixed dose combination pill, the 1 pill once a day, we're hoping to achieve a price of $130 per patient per year, which, as you can see, is now basically either cheaper or at parity, depending on your specific country scenario, with zidovudine-based regimens. Our goal is by 2015 that the first-line, WHO-preferred first-line regimen would be at a cost of about only $100 per patient per year. We also think that there's a lot of opportunity in terms of reducing the cost of regimens going forward, as well as improving the tolerability and potentially even as a result the efficacy due to better adherence of many of these regimens. So there are studies going on right now that are looking at whether or not a reduced dose version of efavirenz can be equally as effective as its current dose. There are new classes of drugs that are entering the market, specifically some new integrase inhibitors that actually finally have the potential to be priced in a much more in a fashion that makes them much more affordable in resource-limited settings than the current integrase inhibitors that we have, as well as analogs or prodrugs to tenofovir coming through the pipeline as well. There's also a lot of work going on in terms of trying to think about new regimen compositions. So do you need to actually have a triple drug regimen? Can you have a PI and an integrase inhibitor? What are some other combinations of regimens that may be able to have equal, if not better, efficacy as well as lower cost? And also looking in the longer horizon at novel formulations, such as injectable products that, again, may have the benefit, especially when we're starting to talk about patients that are being treated who aren't necessarily sick at the time they start and who are going to be on treatment hopefully for a lot longer than patients are today, that this would increase the convenience. Some of the other facility level cost considerations, especially to think of in the context of treatment as prevention, are around, for example, in that other category where we had a lot of expenditure on OI drugs. Are we going to have fewer opportunistic infections if patients are starting treatment earlier and not getting as sick? On the flip side, though, we potentially need more physical facilities to manage the increase in number of patients coming into care. Are we going to be doing fewer CD4 tests if we're basically going straight to a test and treat type of model? On the flip side, as we think about use of viral load coming into standard of care, what does that mean from a cost perspective? And then from a personnel perspective, are we going to be spending less time on retention into pre-ART care? Possibly, but then maybe we're spending more time on adherence support. And on top of that, of course, just as one of the previous presenters talked about, the number of providers necessary in general to treat the increase in potential number of patients. These all, however, need to be taken into account and considered in the context of the overall impact on burden of disease. So a number of these will have positive as well as negative impacts in terms of the healthcare costs, but these investments will also obviously have impact in terms of averted morbidity, longer survival, and averted infections. So the denominator is going to be changing as well. I mentioned that there are other costs. Catherine talked about the investment framework, which is really helping prioritize how those facility level costs are allocated. And as I mentioned, the previous panel has been talking about community outreach and linkages to care and what that might look like. I think the biggest unanswered question that we have, though, this is my last slide, is what do all these costs look like in the real world, in real life? We've seen a number of really interesting and very rigorous analyses done that have modeled a number of different scenarios, looking at these costs, looking at the different way in which treatment as prevention may potentially be rolled out. But as of right now, we don't actually have any on-the-ground sort of country-specific experience. And I think that that's one of the things I'm really looking forward to seeing is how countries, many of whom have presented this week, Swaziland, Zambia, China, as they roll these out on a massive scale, not in a controlled clinical trial setting, what does this actually mean? There's probably going to be many different ways in which this can be approached, and the success of those programs is obviously, as you regress back, going to be influencing the cost effectiveness of them. So that's it for